So super excited for this talk today. So last time I was here, it was kind of a longevity 101 thing. Today, it is going to be about our Empower programs that really for women. So just a little bit on our origin story. So we started BodyTime MD. Well, actually, so the whole concept started 5 years ago, back when I was 67. No, I'm just kidding. But, and then we have the company.
Benjamin Button over here.
But no, I was 40 and just quickly learned that there was a big gap in healthcare. Just trying to get data, trying to get a doctor to kind of do a new age of medicine was lacking. So we built a company around it and we started servicing. And what we discovered was, at least in our women who were our clients, some of them were on hormones, some of them were not. But the care for a woman is just very complex. And what we found is their care was just disjointed. Some women had their primary doctor over here, their gynecologist over here, a hormone doctor over here, and no one putting it all together. And what we also learned is, I mean, we do a lot of comprehensive work. So we look at genetics, cardiovascular risk, cancer risk, all these things. What it all interplays together with hormones and chemicals and emotions and body composition. So again, we had to integrate it all together. And I don't know if you've met my team, but majority of them are women, right? And Kristin was going through her own thing during this. And we just had struggles finding answers, finding care. So then it became, we got to build this in-house. And we did. And that's what this is about. So Kristin Corradini is one of our amazing PAs. She takes care of a lot of our clients, but she really built this program. So it's been launched and we've gotten some great feedback. So this is really going to be more of an educational session. Probably one of many. Yeah. So with that, I'd like to introduce Kristin. She'll take it from here.
All right.
It's 5 minutes, right?
Well, thank you all for coming out. I'm so excited to have this conversation with you all about women's health. So I have some things that I want to say that are important, and I don't want to mess them up, so here they are. This is a conversation that all women deserve to have to make an informed decision about your health. I believe these are the things that we should know, but we should also be doing before we reach this phase. Menopause is inevitable, and we're all going to go through this at some point. So let's be proactive and let's make the most of, let me give you information so you can make the best decision, so we can improve our quality of life. Like Mike said, BodyTime really came in because we saw the gap in the market for women, and we experienced it internally. So there is a lack of communication, a lack of education, misinformation, and what we want to do is we want to help you navigate this phase. So before I get started, I wanted to see how many of you are having concerns with starting hormone replacement therapy. All right. Do any of you have, or are any of you willing to express your concerns?
I've heard that once you start taking them, you can never stop, and it's just, you need more and more and more. I have no idea if that's true.
Okay.
That's one concern.
That's a valid concern. Anyone else willing to share?
Strong family history of breast cancer.
Okay, breast cancer. We're going to get to that today. Any other concerns willing to share? Go ahead.
I feel like it's more about there's just so many options, and so how do you know, right? So the doctor's like, okay, it could be the patch, it could be the cream, it could be the pellet, what sounds good to you? And you're like, I'm supposed to know.
Can you help me make a decision?
Right? Like, how do you really? It feels a bit overwhelming, right? Of all the options, and it's not. There's a lot not known. There's more known, and it's not sort of scientific, right? Something you have a certain illness and they're like, oh, take this 5 times a day for 10 days. It's very prescribed, and this feels much more like, let's see, and that is scary.
Yeah, I agree. We're going to go over risks today, we're going to go over benefits, and we're also going to touch on these concerns because I think that's why we're here today. We want to understand and we want to have the most knowledge to make the best decision. So let's get started. Let's start with the basics. What is menopause? Menopause is the end of ovarian function. The medical definition of this is when you have 12 consecutive months of no menses or surgical removal of the ovaries. Over this time, before you get to menopause, your ovaries are producing less and less of estrogen and progesterone, and that is causing hormone deficiency. So there's a transition stage before menopause that's called peri-menopause. And peri-menopause can start as early as 7 to 10 years before menopause. So that means women are experiencing these symptoms for almost 10 years before they hit menopause, and they may not even know it. So what I want to do today is explain, what are the symptoms? Do we know all of the symptoms? And understanding the symptoms, early intervention, and as well as baseline testing. So when you are 20s, 30s, or 40s, right, before you may become symptomatic, it's great to have a baseline test, because that way we can see our ovarian function when it's in its prime. So in our 20s, right, ovarian function's great, our estrogen's high, our progesterone is great, but then as we get older and maybe become symptomatic, we have a baseline to compare to. So baseline testing is also important. Here are some of the symptoms that women can be experiencing before menopause. So we all know the cliche common symptoms of hot flashes and night sweats, but are we familiar with difficulty sleeping, insomnia, mood swings, fatigue, anxiety, depression, headaches, frequent UTIs, bladder discomfort, and palpitations, and maybe achy joints? These are all pretty broad and vague symptoms, right? As we are women experiencing, I can list 10 of these that I'm experiencing right now, right? So it's hard to narrow this down to, is this hormone deficiency? And what I want to do is just give you the awareness, give you the knowledge that if you're going through this, you can reach out to a provider and say like, hey, I'm experiencing these symptoms and I'm concerned that maybe I'm going into perimenopause or maybe early menopause. Because we know that there are women who can experience these symptoms as early as 27. Another key point that I want to make are that, palpitations, for example, I have several women in my life who, one is a client, one was an ER patient, who've come to me and they've said, I lost faith in the medical field because I was going through what I felt like was a heart attack, experiencing palpitations, chest pain, discomfort. I went to the ER, got an evaluation, EKG, chest x-ray, blood work, everything looked great. And what were they told? Everything looks normal, go see a cardiologist. They go to the cardiologist orders a stress test. Maybe you get extra testing and you get a CCTA and you look at the disease in the heart to say, okay, well, it's normal. Now what are we left to do? We're left to continue experiencing these symptoms, or we find a doctor who maybe can help us and tell us, oh, this might be hormone related. So you don't have to experience these symptoms. You don't have to suffer for these symptoms for 7 to 10 years or even longer in menopause if you're aware that this could be the potential cause. There are two things that we have to discuss when we talk about benefits of hormone replacement therapy. So we know that those are the symptoms that we can experience. Estrogen is related to 300 functions in the body, right? And it's mood regulation, it's metabolism, it's bone health, it's cardiovascular protection. There are a lot of things that estrogen regulates. And yes, we're getting the symptom relief that you saw in the page before, but we're also preventing disease. Like you can see here, estrogen protects cardiovascular disease, protects your bone health, reduces your risk for colon cancer, and also improves or decreases your risk for Alzheimer's disease by 35%. These are all things that can happen when estrogen is no longer in the body. So these are key things that we have to know before we make that decision. So how does estrogen protect the cardiovascular system? So vasodilation, which means the vessels widen and allow more perfusion to the body. We have anti-inflammatory effect. So if you have inflammation in your body, studies are showing that inflammation causes injury to those vessels, and that can predispose you to atherosclerosis. Cholesterol regulation. Women who are, eating healthy, exercising, but go through menopause, their cholesterol levels are going up regardless of even if they were eating the same foods and exercising, right? This is a response of estrogen deficiency in the system. And then endothelial function, it's keeping those vessels healthy from injury. Cognitive function. This has been pretty big in the last few years of realizing that women are experiencing executive function loss. They're experiencing brain fog during these hormone deficiency stages, and they're experiencing difficulty with concentration. 1 in 5 women who go through menopause are quitting their jobs because of executive function loss, meaning they no longer feel like they can perform at the level that they were performing. So that's a huge number. We know that the recent studies show that women who are on HRT, those cognitive symptoms improve. And as long as you're staying on the HRT with the estrogen, estrogen is neuroprotective. It's protecting your brain's neurons. It's increasing neuroplasticity, which is the connection of those neurons. Bone health. Menopause, when you go through menopause, you lose 2% of your bone each year for the first 5 years. Estrogen protects not only stimulating new bone formation, but also inhibiting bone loss. So there's two things that you have to think about when you think about bone health. The structure of the bone, the outside of the bone, right? Being strong, bone density, but we also have to think about resiliency of the bone, like bone, I'm gonna make this word up probably, bendability. So when you fall, your chances of fracture, right? So estrogen is helping that inner matrix of the bone, the collagen fiber matrix, preventing you from, or I guess allowing you to be more resilient when you fall. Risks. This is probably what everyone is concerned about, right? We don't understand the risks of HRT, or maybe we're confused on what the risks are. The biggest risk is timing. So we know through studies that the ideal time frame for women to start hormone replacement therapy is in that first 10 years. The average age of a woman going through menopause is around 51. So if we go through menopause at 50, 60, we have that 10-year time frame that we would want to initiate HRT. Why? Because at 60, we have 10 years of no estrogen, which means now we don't have those protective measures. And really, it's more of the cardiovascular protection that we're worried about. We're worried about how much atherosclerotic disease, how much plaque and cardiovascular disease did you develop when you didn't have estrogen in your body. So if you do start HRT post 10 years, we may have some women in here who are 63 and they're 13 years post-menopause, and they're like, well, can I start HRT? Yes, but now you understand the risks, right? We have to evaluate your cardiovascular risk before we can make that decision to place you on HRT. Route. How many of you have been on birth control? All right. Birth control is estrogen and progesterone. Hormone replacement therapy is estrogen and progesterone. So the risks remain the same. We all know, hopefully, if you were on birth control, the risk of birth control is DVTs and PEs, right? It increases coagulopathy. But that's only with oral route of hormone, right? So if we take hormones orally, it's processed and metabolized through the liver. And that liver metabolism increases our coagulopathy, which then increases our risk for blood clot. So how do we bypass this risk? We go to other routes, which was answer her question. What is the best route? There's no best route, but there is a safer route, right? We have transdermal patches, we have gels, we have creams, we have vaginal creams, there's sprays and injectables. BodyTime MD is using more of the cream gels and the transdermal patches. Now, if you came to me and you're like, I really can't do transdermal, I have allergic reactions, we can come up with another alternative route. But the most common ones that we're using are the creams and the patches. And then hormonal side effects. Every medication has a side effect. So right now, right, if we're in menopause, we have hormone deficiency, and then we have hormone excess. So what our job is to do is to manage your symptoms with the lowest effective dose. So we start you on the lowest effective dose, titrate you up based on your symptoms. By looking at your numbers through labs, by talking to you based on your symptoms, and by slowly tapering that estrogen and progesterone up, we can make sure that we're not getting into hormone excess, which is a symptom. Any concerns or questions on the risks? Okay.
Well, I wondered, are there some hormones that you can take orally that are not as risky? Like, I think progesterone.
Correct.
And oral. Okay.
Yes. Yes. So there are. What research is showing is that you should avoid estrogen and testosterone. Progesterone orally is the safest, but most bioavailability. So you're going to get the most benefit from the progesterone orally. That's a great question, because you're reading this and you're like, well, now I'm taking oral progesterone. Should I not? 9 times out of 10, your provider is going to prescribe you oral progesterone, but your estrogen and testosterone should be through other route. Now, there are newer studies showing that, hey, if we decide your risk, like, do you have factor V deficiency? Do you have a clotting disease, right? If we rule that out, you can take oral pills. But that's just an extra step that a lot of people aren't doing, looking into, what your history is, or if you have it. So why are we fearful of hormone replacement? So we know right now that women are experiencing potentially all these symptoms for 20, maybe 24 years, right? Because we can be perimenopausal 10 years before, and now we go through menopause for about 10 years. So that's 20 years of symptoms that we're struggling with that estrogen can fix. We also know that it's cardioprotective, it's neuroprotective, it's protecting our bone, and it's decreasing our risk for certain cancers. So why are we afraid to take HRT? What is the fear behind it? And it really started with this Women's Health Initiative. How many are familiar with this study? It was a huge study in 2002. It was published, and what it said throughout the media, on the news, magazines, HRT increases risk for breast cancer, which was another question, right? That was another concern. Well, when we look back, we know that this study was flawed, and that its presentation of breast cancer risk was really clinically insufficient or insignificant. So, for example, one of the studies had an estrogen and progesterone group of women, right? And the other one was placebo. So women on the placebo didn't take any hormones. The women on the estrogen and progesterone were taking the hormones. What they found was women in the placebo group, 4 out of 1,000 women developed breast cancer. In the hormone group, 5 out of 1,000 developed breast cancer. We're talking about one more case of breast cancer. How can we say that estrogen and progesterone alone increase that risk? There's genetics, there's lifestyle, family history, right? That can play into that. So they're showing that the study was flawed, but also the results were clinically insignificant. A couple of things that we've also learned since then, and what we found is the average age for this study was 63, right? So we know that at 63, we're approximately at 13 years post-menopause, not in the ideal time frame. Women have been off of estrogen or no longer having estrogen in their system for 13 years. So now we have an increased risk of cardiovascular events, which the study showed, right? Now they're saying it increases cardiovascular risk, increases breast cancer risk, but these women were older and at higher risk for already having these things before being on HRT. And those risks weren't mitigated before the study. Any questions on the women's health? So concerns. We talked about the breast cancer and how it's clinically insignificant, but a couple things that I wanted to bring up and that I've already mentioned is most of us have been on birth control in the past, right? And no one's been informed that birth control increases your risk for breast cancer. And hormone replacement therapy, birth control, the same hormones, different doses. So we know that women who are taking birth control aren't at increased risk for breast cancer. The other point is, I'll move on to the next one because I lost my train of thought here. How long should I take HRT? So that was Kathy's question. Our answer is that we believe women should continue taking HRT throughout their life because of the benefits. If the HRT isn't causing any risks and it's not causing any health concerns, that we want you to stay on it for as long as you can, or that for as long as you choose to, because it's protecting all of those things that we talked about: cardiovascular, neuro, bone. Can I start HRT in my 60s? Yes. So we just have to decrease our risk by doing further testing. So we can do blood work that looks at cholesterol levels, Boston Heart, that's a more specific test, and then we can also do CCTAs that look at the coronary arteries to see if there's actually plaque buildup. Every action that a human being takes involves risk, and what we want to do at BodyTime MD is decrease that risk for you. Mike spoke about this earlier, but we really do a comprehensive evaluation on hormone replacement therapy. We do a significant medical records review. We sit down with you for 60 minutes and really get to know who you are and what you do. Family history, a lot of people aren't familiar or don't know what their family history risk is. And so just going back home and asking your mom and your grandparents or your brothers and your sisters what you have, and that knowledge helps us decide what your risks are. We do an extensive lab. We do the CBC, the CMP, the hormone panel, but we're also doing a Boston Heart that looks at how you're producing cholesterol. Are you an absorber or are you a producer? This information is helpful for when we decide to treat. So we can block cholesterol by fiber in the diet, increasing the fiber in the diet. Or maybe we do lifestyle modifications at first and then place you on a statin if those numbers are not improving. So we are doing a comprehensive evaluation, but making sure that if you are symptomatic, those symptoms are due to hormone deficiency and not to something else. And that brings us into what we do at EmpowerHer. So like I spoke, we have a couple special tests. Another test that we do is a anti-Müllerian hormone. So this is really for women who are in the perimenopausal state, that we could actually predict when maybe 5 to 10 years when you can go into menopause. So this number, if you were to do it early in your 20s and 30s when you're not symptomatic, this number is going to be really high, right? Because you have a lot of follicles, you're still ovulating, but as you become symptomatic, now we can trend that number. And as it goes down, we can tell you, okay, we're about 5 to 10 years out from menopause. And that information is important because what can we do in that 5 to 10 year mark? We can improve our diet, increase our bone mass, increase our lean mass, and you can trend this data as you become symptomatic and throughout those stages of your life.
I have a question.
Yeah.
Can you talk for a minute about what a DEXA scan is?
Yeah. So a DEXA scan is what we use to look at lean mass, bone density, and it also looks at fat mass, right? It's an easy test that takes about 10 minutes. It's using X-ray, right? And what we use this for is for determining your risk for osteoporosis, or maybe, when you start the program, we're looking at where you were to where we want to get you. So a lot of women, before they go into menopause, they think, you're all thinking, I probably have great bone density, right? And then you get your DEXA scan and it's showing that your bone loss, you're in the, the -1 standard deviation. So this puts you at risk for osteopenia and osteoporosis. So we're using this as your baseline test to show where you are, but where we can get you with exercise, nutrition, and strength training. So we have 3 different types of programs. We have the Consult, the Essential, and the Elite. The Essential is our most popular, so this is for if you want to get the blood work done, the DEXA scan with us, and we provide that plan of care. The Consult is for if you were already seen, maybe you were recently seen by your PCP, or you've been at a hormone clinic and you no longer want them to do your care, right? I can interpret your previous blood work and give you a plan of care. You can decide whether you want to stay with us with the treatment plan, or you can go back to your provider, your PCP, or maybe continue doing lifestyle modification. The difference between the Essential plan and the Elite plan is we give you the Oura Ring and the continuous glucose monitor. Anyone familiar with the Oura Ring? Yeah, so the Oura Ring is really great with sleep tracking. activity and recovery. So we get the backside data on that, so we're able to help you throughout your sleep. Talking about maybe is it sleep latency, you're not going to sleep, you're falling asleep too soon, you're falling asleep too late, you're not getting enough deep sleep or REM sleep. We can kind of educate you and provide that information and help improve those sleeps. Or for instance, if you're not on progesterone, you get on progesterone, what do those numbers look like afterwards? So it's great for data-driven people too. Continuous glucose monitor is giving you real-time glucose measurements. This is important when we talk about, changing our diet or looking at how our body responds to certain foods. So we really don't want these big spikes up and down. We want to keep that glucose in a pretty steady state. And so with that, you can track your food intake for a month. Once you get your treatment plan, we then go to monthly maintenance plans. So this is when you will meet with an APP monthly, and it really determines what your needs are. So lifestyle management is probably for more of the peri-menopause, maybe milder symptoms, and or women who are not symptomatic at all. Maybe you're 20 or 30 and you just want a baseline test and you want someone to help you through strength training, nutrition, exercise, sleep. That's what this plan is really built for the women who want to see their baseline levels and improve with lifestyle modifications only. The hormonal management is perimenopausal, moderate to severe symptoms, and women who were titrating on hormone replacement therapy. The medical direction pathway is for clients who we find may have developed, or we find that they have cardiovascular disease or something else that we need to look into. So my job is to be your hormone specialist, but the medical direction is for those things that we don't know. Maybe you have a significant family risk of breast cancer and we want to get a full body MRI and we want to get a mammogram, and we have other decisions to make before we start hormone replacement therapy. Medical direction is allowing you access to a physician quarterly to order those testings so we can mitigate that risk, right? Also great for if we find out you have significant cardiovascular disease, your cholesterol levels are in the 300s, we find plaque buildup on your CCTA or calcium score. Now we have to determine, do we want to start you on HRT, or is this risk not worth the benefit? So medical direction pathway is for that. All right, any questions?
So you said that if, let's say you're in your 60s and you do the CCTA and all the cardiovascular testing, so there is a risk that when you go on HRT when you have cardiovascular issues?
Yeah, great.
What are the risks there?
Yeah, so what we know from research is the first year of HRT with cardiovascular risk, there is a risk for those soft plaques to break off, and you have a higher chance of heart attack and stroke in that first year. After that first year, that risk decreases. So it's a decision that we have to make, and you have to make, whether you want to, maybe have a risky first year, but also get the other benefits of what estrogen provides you. But that is the risk the first year.
So depending on the level or the severity of the disease, then you just maybe kind of drip it in even slower, the hormone? Or does the dosage?
So it's not so much the dosage is the estrogen in general increases that risk for the first year because of the vasodilation, the soft plaques. It's more easy to break off and cause injury. So that is if you have. So for example, we have a 73-year-old who has high cholesterol, and we did a CCTA, and there's 0 plaque, right? So we were expecting disease, but when we looked into his arteries, there was actually no plaque. So for instance, if it was a he or she would not be at risk for developing that because there's no disease.
And I guess my question would be, so let's say you're on HRT now, but as you go through that 10 years of menopause or whatever it is, maybe you need more and more and more. How often do you check? Is it really based on symptoms?
If you are already in menopause, it's based off symptoms. Okay. So most women experience menopause symptoms for 10 to 14 years, but if you're on estrogen and progesterone, how would you know if you no longer have symptoms, right? If those symptoms are going to go away, what you now have is the benefits of what estrogen provides you. The cardio protection, neural protection, bone health. So that's what you're getting if you're staying on it for the rest of your life.
But will you need to titrate up, to Jeff's point? No, you just kind of, whatever works for you, once you find whatever's working for you, it's going to probably work for you for those 10 years.
Or you could go into hormone excess, right? So we would be trending those numbers to make sure that we're not making you hormone excess, but you're still in that sweet spot of no symptoms, or because you're not experiencing symptoms, there's no adverse side effects that you're experiencing.
And then after 10 years, do you stop?
You can, but that's a decision that you make, right? Because stopping, what we know from research is that stopping estrogen and or progesterone increases your risk for developing all of those things again.
Even after the 10 years.
Even after the 10 years. Those things are protecting you. Once you stop, cognitive function declines again. Studies are showing that. Cardiovascular risk increases, and bone health.
Yeah, bone density is the one that really, really comes to my mind, right? So as you get older, it gets more difficult to do fitness. I'm not saying it's impossible, but the work becomes harder, right? So again, the way I look at data is it's only meaningful if you trend it. So you get a baseline DEXA scan. Let's say your bone density is not great. It doesn't mean that's set for life, right? You can continue to build that. So let's say an individual gets on HRT. We're doing great work with them. They're doing the strength training and building up their bone density, and that trend looks great. Yeah, you probably have some options there, right? You build this surplus, and now you're gonna be on a decline once that estrogen comes out of the picture. You need estrogen to build bones. So again, it becomes a decision point, right? But let's say someone isn't building. Well, that's a different conversation, right? Because we know that that bone density is going to fall off.
How is it that guys don't have this problem? Seriously, I mean,
Yeah.
why do we get all the shit?
I'm right here today.
We have to birth these children
So,
out our
right.
nostrils, and then
This questions come up, right? It's like, why does menopause happen? You know what I mean? And it doesn't make any sense, right? And I think, like evolutionary, like
caveman wise.
yeah, caveman wise, right? Well, I mean, it's like the body was designed that way. It's like a woman makes babies, and you served your purpose. Correct. I mean, it's blunt as that sounds. Like that's how the body was designed. Yet society.
With it for 40 years longer than we did in the caveman.
Correct.
Yeah.
Correct. So the society has evolved, and now technology has to evolve with it.
Yeah. I mean, in the early 1900s, women were living to 50. So they were living to menopause. Now we're living to 73, and that's the average age, but there are many women that are living to 80s or 90s. That's over half our life without estrogen. So.
Right.
I wonder why testosterone is not something that has been talked about.
Yeah. So testosterone, we're still producing. The ovaries produce estrogen and progesterone, but testosterone can decline. But in women, we base it off of symptoms, and we're not really looking at a number. So do you have low libido? Are you having trouble developing muscle mass? These are all things we can add. We can add testosterone, but your body's still producing it. It's not like the ovaries are no longer producing it. That's what's happening with estrogen and progesterone, is the body is producing maybe 1% of what it used to produce.
Okay, so if someone is having, if their blood work or their testosterone level is low or they're experiencing symptoms, it is something that you prescribe.
Yes.
Yeah, so hormones are pretty complex. So within an individual, like in a woman, there's an interplay between testosterone and estrogen. So testosterone in some women is needed to boost the estrogen, and maybe not in others. So again, it's really trending the data and seeing how the body responds and tinkering, right? So hormones, it's not something we get a snapshot, throw a bunch of stuff at you, and then you're off to the races. It's very sophisticated. Unfortunately, that's not necessarily how it's offered. You know, it depends on your provider. Like Chris and I have talked about testosterone in men. I mean, that whole industry just went a direction that I don't believe in. In fact, like we don't have any clients that we've started testosterone on in men because we haven't had to, right? Now we can make a big boast on that, but that's the truth, right? You can naturally boost it. You know, so in women and men, it's let's see what you can do naturally, and let's see where you're at, and then let's tinker, right? But it requires a close touch, you know.
Kristin, you talked a lot about hormone replacement in those years after menopause, but how do you determine, well, first of all, is it prescribed while a woman is still ovulating?
Well, yes. For perimenopausal women, it's more supportive doses versus replacement doses. So we know that you're still ovulating, you're still producing some amount of estrogen, progesterone. We don't need to replace all of it. So we give supportive doses to improve those symptoms. So you can go throughout your life without, this debilitating symptoms of now you have this new onset depression, anxiety, or you have UTIs or palpitations or joint pain. So we can improve those symptoms even as early as, 30s, 40s, depending on when you become symptomatic.
If your levels of estrogen are going down in the lead up to menopause, are you having bone density loss, cognitive decline in that lead up to menopause? Or is it only after menopause?
The studies are showing the significant drop in menopause when there's no hormones really being produced. But I'm assuming that, you're losing a little bit, right? As you age, you're fighting against the muscle mass, right? The bone density. So there are all those things that we're constantly fighting from age 30 on. But I think it's most significant when the hormones stop being produced as much.
Bone density is interesting. So this is something that, as I went down all these longevity rabbit holes, I learned a lot was kind of too late for my wife and I, and a lot matters more so for our kids. So in terms of bone density for women, it really comes down to what is your starting point, and your starting point is determined by the activity you're doing from ages 8 to like 22. So the girls that are doing like gymnastics or like a lot of the vertical compression exercises really builds up this huge surplus of bone density. And I've just seen some of these women are just off the charts on their bone density. You dig in the history and their story is way different. I was a gymnast. I was doing intense volleyball stuff. I was a farmer and doing all kinds of crazy work. And you just see like they're just standard deviations above norm. Well, the reality is they have a lot more to lose. They have a lot more bandwidth, right? And some of that you just don't know until you get the data, right? Now, everyone, once estrogen falls, that bone density is going to decline. You can mitigate that by doing intense strength training and really resistance training. You can build that, but it's just some people just have a different starting point.
But you said once estrogen falls, not stops. Because I'm most interested in the decline.
Yeah, and so yes, so like once estrogen is less in your system, you can build less efficiently. Does that make sense?
Yeah.
Yeah, and one thing we really like, and I'm going to talk about Kristin's health, but there was a rapid decline in symptoms in her, like within 43, something like that. Her mom went into menopause right around 45, and it was one of those, had a baby, next year menopause, right? But this anti-Müllerian hormone is pretty cool. It's a new age test, and if you're high, you can definitely say you're probably outside of 5 years of going into menopause. But if you're low, you're probably within 5 years. Right, so the conversation, the decision we had, her anti-Müllerian was very low. So the decision, it's not like it's a bad thing. It's just, it's like, it's real data. I mean, that's what her data showed, right? But the decision was, okay, what do we do? Do we wait to do hormone replacement, or we start now? And do we mitigate the bone risk? Her density was good. It wasn't terrible, but she was symptomatic, and we know you're in menopause, like going into menopause as we speak. So we started.
Yeah, that's my question.
Yeah.
In the years leading up.
Yeah, we started. Mm-hmm.
Yep.
Helped with her sleep. I mean, like all these other things. I mean, there were all these benefits. Mm-hmm.
So out of all these symptoms, how do you know it's definitely from the hormone change versus the other thing?
It's tricky, and I think that's where the power of baseline testing is, right? So like, let's say someone had testing when they were in their 30s, right? Ovulation prime. And they're normal. And let's say you have some issues. Yeah, my sleep was off, anxiety was whatever. And we can see your hormones are good. And let's say later we have something to compare against, right? So it's tricky because a lot of these symptoms, I mean, the list is long on the possible causes of them, right? So it's tricky. So it requires kind of close monitoring, see where you are, tinkering and then following up and see how those symptoms improve, right? But baseline is so crucial. Like, at least for my daughters, like, I'm gonna get some baseline stuff when they're 10, 20 years from now. So the other thing with the Women's Health Initiative, they were using a really antiquated version of progesterone, like a synthetic version that we don't even use today. And there's thinking that that was probably a contributor to some of the cancer risk. So that study just caused so much harm for many, many years on women getting access to hormones.
Prior to that study, 75% of women were on HRT in the 1990s. After that study, only 25% were on HRT. Like, providers weren't prescribing it. Providers are still reluctant to prescribe it. So we're in a stage where it's changing, but it's slow, and you have to seek out a provider who aligns with, HRT.
Right. Yeah, we have a woman client. She kind of fought against the grain to remain on HRT, and she says all of her friends that kind of discontinued, I mean, they're just in a different state. This woman's flourishing. She's climbing mountains and riding bikes and doing all this crazy stuff.
Has insurance caught up, and is it supporting hormone therapy for women now, or is it this most is out of pocket?
Yeah, I mean, so yes and no. So, like, prescriptions, can be covered. It depends on the level of testing, but yes, it's definitely catching up. We're entering a world where it's getting normalized, as it should be. Yeah.
Are there different forms of estrogen that are less systemic? So if you have a higher risk profile and perhaps you're trying to alleviate certain symptoms, are they all the same, or are there some that it's a cream or it's more localized, or any thoughts around?
In general, what we found is skin tolerance. So some people really have a hard time tolerating the transdermal, the sticker. It's basically just irritating. The gel, it's more of a dispensary challenge. Like everyone says, it comes out as a bigger blob than the other blob, and I go on a plane and I lost half my bottle. It's that kind of stuff. But in terms of efficacy or risk reduction, I think it's all pretty much the same. And in my head, it's like, I wouldn't look at it as any kind of cancer risk, but I get it. Some people have an emotional thing to it, right? If you have a strong family history, like, I just want to know, mitigate it to the best degree that you can with the technology. Awesome, we got all the tech for that, right? There's blood tests to look at cancer genetics floating in your bloodstream. Mammogram is definitely baseline, coupled with an MRI. Those two tests can really, really essentially eliminate any kind of breast cancer risk, right? Each one looks at different things. A mammogram looks at more calcified tumors, and an MRI will look at more soft tissue. So the two of them combined can be very powerful. So we would do all those things, right? And then I can say definitively, with all the tech on the planet today, I mean, your risk is as low as it can be. And you can make an informed decision at that point. But thank you so much for coming.
Thank you.
Thank you.